Okay. So, hi, evening, friends. Evening, everybody, bache. Evening, everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And before we even start the session and before we even go forward, I guess, कैसे हैं हम लोग? I know we have in our live classes, we have just finished both path as well as microbiology in a gap of just 2-3 weeks. So, this INI session, frankly, it is going to be extremely beneficial, especially for the students who have watched the live class, have covered MCQs of these two subjects, and will be listening to this. साइड बाय साइड अविनाश आई नो बच्चे आई नो कि यू आर हैविंग लाइव क्लास साइड बाय साइड कोई बात नहीं उसको या तो रिकॉर्डेड पे देख सकते हैं बाद में या इस वाले को देख लेंगे समझ लेंगे देखो परेशान नहीं होना है either ways if you those students who are already attending the live class you can continue with the live class you can see this part later or vice versa. Suppose you want to take a break from that and want to quickly revise the previous 4-year PYQs. But the bottom line is, इसको please साथ साथ देख लेना. That is all I want to say. So let us start. And as usual, you know this very well. Keep on telling me the answers side by side. We'll first have a look at the pathology MCQs and we'll follow it up with microbio. Evening Preeti, evening dear. So evening Abdullah. Nice to see you guys after long, I guess. So let us start. Let us start with our first question. All these questions which I have put, these are the exact questions which came in your paper. This is the type of paper that we expect in INI exam. So let us start. Let us start with our first question. Answer. Keep on telling me the answers. That is seriously so sweet. देखो classes दोस्त दोनों करनी है. So and this is what actually happens sometimes, that if we like a particular subject for whatever XYZ reason, we are always happier attending that. But in the end, all 19 subjects have to be covered well, because our motto is to clear this paper with an extremely good rank. नहीं श्वेता somebody else also told the answer, वो गलत आंसर था तो then you deleted. देखो एंटी इन्फ्लेमेटरी पूछा है ना बच्चे, एंटी इन्फ्लेमेटरी साइटोकाइंस आर ऑल except which are the three. No, wait guys, wait. Shweta, Kartikeya, Preeti, बच्चे गड़बड़ हो गया. When you tell me the answer is interleukin 10, ये तो बिल्कुल गड़बड़ हो गया. Remember which we always talk about pro-inflammatory mediators. Which are the three main anti-inflammatory mediators? They are interleukin 10, TGF beta, transforming growth factor beta. TGF beta was asked this time in NEET PG PYQ. We discussed that. TGF beta and lipoxins. These three are anti-inflammatory. You know that. Whereas interleukin 4 and interleukin 6, these are both. They play a role in both. They are both pro and anti-inflammatory. So I will consider them as anti-inflammatory also. Interleukin 10, interleukin 6, I'll consider this as anti-inflammatory. Next, I know anatomy थोड़ा सा है वैसा, but कोई बात नहीं. Coming back, interleukin 1 receptor antagonist. See, most potent pyrogen is interleukin 1 followed by interleukin 6, you know that. If it is a receptor antagonist, IL-1RA or IL-1R, that is receptor antagonist, if it is antagonist to it, it is anti-inflammatory. So what is the answer left by default? That is tumor necrosis factor, TNF alpha, beta. Those are the ones which play a major role in sepsis. They play a major role in sepsis, making the answer as 4. Next question. Have a look at this now. In this question, I want 100% right answers. So these are the questions in which, one more thing, when I'll be taking care of path and micro today, it will not just be limited to path micro. We'll be integrating it with medicine also. So there will be many points of medicine covered in this session with respect to these particular topics. Now, a 54 male presented with diffuse swelling of the lower lip for the past 5 weeks. Biopsy shows non-caseating granulomas. It shows the presence of non-caseating granulomas with fibrosis. So, when we talk of sort of nahi bache, dekho, there are mainly 2-3 things in this question. We can divide granulomas. अच्छा, इसको ऐसा करते हैं, थोड़ा सा और देखते हैं इसको. We can divide granulomas and we don't have to delete our answers. और अगर आंसर गड़बड़ हो गया तो डिलीट थोड़ी करना है दोस्त. We can divide them into two types. That is those with caseous necrosis, caseating versus non-caseating granulomas. You know that. When we talk particularly with respect to caseous necrosis, our first DT is TB. Other than TB, which fungal infection shows the presence of caseating granulomas? That is histoplasmosis. That is histoplasmosis versus non-caseating granulomas, which is seen in hypersensitivity pneumonitis, and sarcoidosis. So the minute you have a history of non-caseating granulomas with bilateral hyalurolymphadenopathy, examiner is taking you towards sarcoidosis. In GIT, it is also seen in Crohn's disease. In GIT, it is also seen in Crohn's disease. Hi, evening Jayesh, evening everybody those, evening everybody. So this is the master table with respect to granulomas. Acha, tell me two more answers. Dark granulomas. Tell me this. Dark granulomas are seen in dark granulomas and stellate granulomas. I'm waiting for your answer on this. Dark granulomas are seen in malaria. Which malaria? Plasmodium falciparum. They are associated with malaria, that is Plasmodium falciparum. Versus stellate granulomas. Stellate granulomas, that is the central necrosis with peripheral infiltrate by neutrophils. Stellate granulomas is a feature of cat scratch disease. It is a feature of cat scratch disease. Ishika kuch bhi nahi. Matlab this is just our second or third question. You just missed out on few wrong answers. Aur kuch bhi nahi bache. And so stellate, cat scratch. Agreed. So this was with respect to granulomas. So coming back to this question, examiner was talking about non-caseating granulomas which are seen in both sarcoidosis and Crohn's disease. TB was out in this. Okay, now have a look at the examiner talking about lower lip swelling or granulomas in the lower lip. If it was a case of Crohn's disease, which is the most common site of involvement of Crohn's? Most common site of involvement being ileum. We will differentiate Crohn's versus ulcerative colitis. Fatafat se abhi. It is asked, it is an important topic in GIT medicine, so we'll have a quick look at this. So making the answer as sarcoidosis in this case. Next point. अच्छा, इसमें एक चीज और देखो. We can divide inflammatory bowel disease. We can divide IBD into two types. That is Crohn's disease versus ulcerative colitis. सबसे पहले tell me about IBD. Male, female, age group. When is it seen? When is inflammatory bowel disease associated? It is associated with hygiene hypothesis. Hygiene hypothesis tells us that we keep on going to dhabas all the time. Girls are sophisticated. Their parents always take them to restaurants and 5 stars. When is the first time a girl goes to a dhaba? With us. So the guy's stomach is used to the bad food, whereas in the girl, it leads to immune activation leading to IBD. So girls, age group. So I can safely say IBD, it is female predominant age group. When do we start going out? No double meanings, just to have food, I guess. Teens and early 20s. Age group, teens and early 20s. This is about IBD. Main inflammatory cell, T cell. So IBD, it is divided into two types, Crohn's versus ulcerative colitis. In Crohn's disease, it can involve anything from oral cavity to colon, but rectum is spared. It can involve anything, but rectum is spared. Rectum is not involved in this. Most common site of involvement is ileum. And as you already told me, it is associated with the presence of skip lesions. Skip lesions means if this is ileum, it is involved normal, in turn giving it the classical cobblestone mucosa appearance. In turn giving it cobblestone mucosa appearance. This is Crohn's versus ulcerative colitis, which is totally opposite. In this, rectum is always involved, and it shows the presence of continuous lesions. Rectum is always involved and it has continuous lesions. Meaning, so understand this in one go. If this is the ileum, ileocecal region with appendix, ascending colon, transverse colon, descending colon, rectum and anal canal. Rectum is always involved. After that, it will be a continuous lesion. So first descending colon is involved, then will be transverse colon, then will be transverse colon, then is ascending colon. When the disease goes back to ileum, it is called as backwash ileitis. So ulcerative colitis, it was a continuous lesion and it is associated with backwash ileitis along with toxic megacolon, because peristalsis is not taking place properly, so it has a toxic megacolon. Agreed. So this is Crohn's versus ulcerative colitis, the gross appearance. Crohn's is the one which is associated with granulomas and fissures. This is the one which has granulomas, inflammation everywhere, transmural inflammation and fissures. Versus ulcerative colitis, which is associated with the presence of pseudopolyps. Pseudo is false polyps. Normal mucosa looks elevated. Ulcerative colitis, it is associated with pseudopolyps. Cancer risk, malignancy risk is a feature of ulcerative colitis. Malignancy. Which malignancy are we talking of? Colon cancer. Which was involving the colon? Crohn's ulcerative colitis. Ulcerative colitis involves colon. No? So colonic carcinoma is a feature of ulcerative colitis. First class. So this was the master table of Crohn's versus ulcerative. We saw non-caseating granulomas were seen in both Crohn's as well as sarcoidosis, but the history pointed us towards sarcoidosis. Agreed. Agreed. Next question. Which enzyme is associated with SCIT? This gets us to the next one. This gets us to the next question. Which enzyme is associated with SCIT? Severe combined immunodeficiency. Again, a modification of this question was recently asked in the PG segment, MBBS PG segment. It is a disease of adaptive immunity. It is a combined B and T cell defect. It is a combined B and T cell defect, SCID. The name tells you everything. Severe combined immunodeficiency, it's a combined B and T cell defect occurring due to ADA deficiency, which is occurring due to adenosine deaminase, occurring due to ADA deficiency, SCID. Let us have a look at option A. Asya Musa, you were thinking of HGPRT deficiency, that is hypoxanthine guanine phosphoribosyl transferase deficiency. This deficiency causes Leishman syndrome. This is associated with Leishman syndrome, not important with respect to path at all. With respect to pathology, we only talk with respect to SCID. There are two diseases of adaptive immunity that we need to know. SCID, severe combined immunodeficiency, that is ADA deficiency, autosomal recessive, and the next is Digeos syndrome. We'll see that. HGPRT, this is Leishman syndrome, which is associated with gout, self-mutation, and neurological dysfunction. Leishman syndrome, the patient presents with gout, self-mutations, and neurological dysfunctions. Versus xanthine oxidase deficiency. Xanthine oxidase, this is an enzyme which is involved in purine metabolism. So deficiency leads to reduced uric acid production, like especially with allopurinol use. Agreed. So that is with respect to xanthine oxidase. SCID is bubble baby. We call him as a bubble baby because it is a combined deficiency of both B and T cells. So it is associated with increased risk of infections by mild organisms or severe organisms. Mild organisms. Opportunistic infections, the ones our body fights off. This patient is not able to fight them off. So it is associated with increased risk of infections by EBV, CMV, cytomegalovirus, adenovirus, influenza virus, rotavirus, and so on. Influenza virus, rotaviruses, and so on. This was SCID, severe combined immunodeficiency. Acha, one more thing. This gets us to our next important topic, that is Digeorge syndrome. Now, SCID was it was a deficiency of both B and T cells. This gets us to Digeorge syndrome. Let us have a look at this here only. Digeorge syndrome, bache, this is only a T cell defect. This is only a T cell defect. Which is, where do T cells mature? They mature in thymus. So clinically, the minute you have a history of thymic hypoplasia with hypocalcemia, cash 22, totally agreed. With hypocalcemia, calcium is reduced. In our body, if calcium is reduced, it can lead to seizures. That is, it manifests as neonatal seizures. Developmental delay with delayed milestones. That is a case of Digeorge syndrome. Tell me the familial inheritance with this. But this was given in the question itself. Young child with thymic hypoplasia, history of seizures since birth, and delayed milestones. Which is the familial inheritance associated? I'll be very glad if you tell me the answer to this, especially our live class students in which anatomy is going on. From anatomy, you very well know with respect to the pharyngeal pouches. So we can divide inheritance into two broad categories, that is familial versus non-familial cases. Familial cases, but this is associated with developmental defects. In third and the fourth pharyngeal pouch. So please note, whenever we talk of Digeorge, we should not just jump to cash 22, that is chromosome 22q11 deletion. That is non-familial. Chromosome 22q11 deletion, again important. This is important. This is non-familial. Familial cases, they occur because of developmental defects in third and the fourth pharyngeal pouches. Pharyngeal pouches, which are not pharyngeal arch, pharyngeal pouches. You know the difference better than me from anatomy. So this was Digeorge syndrome. We are doing this, we are not just sticking to the questions, but doing one extra topic. We are doing one extra topic along with each of these because it is always the same topics which are repeated, not the questions. So when you are doing it on your own also, so always when PYQs are being done, always read up uske thoda sa upar niche also. It is very beneficial. Next point. So this gets us to our next question, that is pernicious anemia. Now I guess all of us are very comfortable with respect to pernicious anemia. Which hypersensitivity? मुझे इसके बारे में एक दो points बता दो. It is which hypersensitivity? Next point. It is a special type of megaloblastic anemia occurring due to antibodies against intrinsic factor. You know this, that vitamin B12 binds with intrinsic factor, and this vitamin B12 intrinsic factor complex is absorbed from terminal ileum. You know that. Intrinsic factor, but it is secreted by parietal cells of stomach. It is secreted by parietal cells of stomach. You know this, you know all this. So which hypersensitivity? I am waiting for your answer on this. It is associated with antibody against intrinsic factor. So antibody mediated hypersensitivity, that is type 2 hypersensitivity. Antibody hai na bache? It is associated with antibodies against intrinsic factor, that is type 2 hypersensitivity. It leads to a deficiency of vitamin B12, that is, it is associated with the deficiency of cyanocobalamin. Vitamin B12 deficiency, that is cyanocobalamin. ठीक है, मान लिया. Riboflavin deficiency. Riboflavin deficiency. This is vitamin P deficiency, vitamin B2 deficiency that is associated with a riboflavinosis. Agreed. Agreed. Majority of us were right on this. That is cheilosis, glossitis, and corneal vascularization. Normally, our cornea, it is avascular in nature. Vitamin B2 deficiency, that is riboflavin deficiency, causes corneal vascularization. Cheilosis, glossitis, that is at the angle of the mouth, there is dryness with corneal vascularization. Niacin is vitamin B3. Niacin is vitamin B3 versus thiamine, which is vitamin B1. Niacin deficiency causes pellagra. That is diarrhea, dementia, dermatitis, and death. The 4Ds of pellagra. 4Ds of pellagra, that is niacin deficiency, diarrhea, dermatitis, dementia, and death. And lastly is vitamin B1, that is thiamine deficiency, which causes beriberi or agreed, which causes beriberi or Wernicke-Korsakoff syndrome. This is with respect to deficiencies, the vitamin deficiencies. Next question. 100% right answers in this. मतलब इसमें तो कोई doubt ही नहीं है. Along with tell me another 3-4 questions, commonly asked questions with HIV. Most common malignancy with HIV. Let us have a look at few salient features of HIV here only. Most common malignancy associated with HIV. Next point. Most common renal disease with HIV. Most common renal manifestation with HIV. Next question. If CD4 positive T cell count is very low, if it is less than 50 cells per microliter, it is characteristically associated with which infection? I'm waiting for your answers on this. Next question. Most common SOL, space occupying lesion in CNS in HIV. Keep on telling me the answers side by side. Reena, Anvesha, बच्चे थोड़ा सा गड़बड़ हो गया. Abdullah, Asimio is sort of bang on right. When we talk of most common malignancy with HIV, please never ever say it as Kaposi sarcoma. Never. Most common malignancy with HIV is NHL, non-Hodgkin's lymphoma, followed by Kaposi sarcoma. बच्चे most common is NHL, non-Hodgkin's lymphoma, followed by Kaposi sarcoma. It changed 7-8 years ago. Kaposi sarcoma, it is a malignancy of the oral cavity. So most common oral malignancy with HIV. So we'll have to see the question very carefully. Most common oral malignancy with HIV being Kaposi sarcoma. Next point. Agreed. Most common space occupying lesion in CNS in HIV. Space occupying lesion means anything that is not normal. It can be infection, cancer, lymphoma. HIV, it increases the risk of all three. It increases the risk of infections, it increases the risk of cancers as well as lymphomas. But most common is infection by toxoplasmosis. Most common is infection by toxoplasmosis. Next, I was thinking many of you will answer me this question also. If CD4 positive T cell is very low, it is associated with CMV infection, and CMV infection of which site? Which it is associated with CMV retinitis. And lastly, renal manifestation with HIV. I guess all the double meaning, all the naughty people out there, Jayesh, if he is still here. So Jayesh, sort of Abdullah. Most common renal manifestation. Easy to remember. Patient went to have some fun, but his whole world collapsed around him. So in the kidney, it is associated with collapsing glomerulopathy. In the kidney, it is associated with collapsing glomerulopathy. So these are the one-liners with respect to HIV that we need to know. Next point. So which of these infections are seen in HIV? It is associated with EBV, varicella, herpes, making the answer as D. All of these. Acha, another question that is asked, let us do this here only. Kaposi sarcoma, it is associated with another virus, that is HHV8, human herpes virus 8, HHV8, which is associated with 3 diseases, that is Kaposi sarcoma, primary effusion lymphoma, that is Kaposi sarcoma, primary effusion lymphoma, primary effusion lymphoma, and Castleman disease. You know this. Next question. This gets us to a very factual question. एक बार read the question carefully. The minute you see this image, you are able to make out he is a young male child presenting with hemarthrosis, presenting to the OPD with hemarthrosis, that is severe swelling of the knee joint, or it can also present with deep thigh hematomas. It is associated with hemarthrosis or deep thigh hematomas. You know this. So which, just this, forget the question at present. Which hemochromatosis? Nahi dost, not at all. When we talk of hemochromatosis, which is the sexy skin color? Bronze color. We are talking of bronze diabetes. Excessive iron deposition in the body. Where most common site is liver, followed by pancreas. So because pancreas is getting deposited, it is called as diabetes. And what is excessive iron deposition called as? Hemochromatosis. Which, when hemosiderin gets deposited in the skin, hemosiderin is brown in color. We are dark skinned because of melanin. Melanin is black in color. So it gives us a sexy skin color, that is bronze color. That is bronze diabetes, hemochromatosis. H for hemochromatosis, H for HFE gene mutation, chromosome 6p. Short arm of chromosome 6. HFE and HLA, they are present on same chromosome. इसको will not call it as hemarthrosis also, no. इसको कुछ hemarthrosis, अच्छा, you were talking with respect to this presentation. Fair enough. This is hemarthrosis with deep thigh hematomas. Tell me the diagnosis first. Asam here nahi bache. Nahi. Now this was a very factual PYQ. So first tell me the diagnosis. What do you think is happening here? Hemophilia. It can be hemophilia A or B, which occur due to deficiency of coagulation factors 8, 9. You know hemophilia ABC, deficiency of coagulation factors 8, 9 and 11. What is the inheritance of hemophilia? It is X-linked recessive, that is, it is male predominant. You know that. Sabse pehle, now, what is the examiner telling you? He told you that patient has hemophilia. When this question came, the image was not there in the question. He told you the patient has hemophilia. Which hemophilia has he? Has factor 8. That is hemophilia A is 0.25 international units per ml. They gave you the factor 8 levels. Bache, this is not severe. This is factual. It is mild hemophilia. Dekho. When we talk with respect to mild hemophilia, the coagulation factor is 5 to 40% of normal. It is 5 to 40% of normal. That is 0.05 to 0.4 international units per liter. Normal, we take it as 1 international unit per ml. Normal, keep it simple, is 1 international unit per ml. So 40% of it is 0.4. So 5 to 40%. You can remember it either way. 0.05 to 0.4 international unit per liter or 5 to 40%. That is mild. Moderate is 1 to 5. Severe is less than 1. तो less than 1 severe है, मतलब 0.01 से कम हो गया ना, 0.01 international units per ml. 1 to 5 means 0.01 to 0.05 international units per ml. It is the same thing. कान को चाहे ऐसे पकड़ो चाहे घुमा के पकड़ो, बात वही है. So this is a case of mild hemophilia. This is a very factual point. Mild is 5 to 40% of normal. Moderate is 1 to 5%. Less than 1% is severe. This is mild, moderate, severe hemophilia. In our case, it was a case of mild hemophilia. It was mild क्योंकि 5 to 40%, 0.05 to 0.4 international units per ml. 5 to 40%. Mild hemophilia. Everybody, please give me a thumbs up if all of you are comfortable with all the points that we have done till now. Everybody. एक बार please give me a thumbs up, like the video or put a heart if all of you are comfortable with all the points. And then we go to our next very important question. This is a question from blood cancers. So don't ask me why, but the chances are very high that this might be asked in your paper. Now, what is the investigation of choice for detection of fusion transcripts? Investigation of choice for detection of fusion transcript. Any fusion transcript like CML, it is associated with which fusion transcript? BCR, ABL. Any fusion transcript, but the investigation of choice is FISH. Fluorescent in situ hybridization. Investigation of choice is FISH. This is what it looks like. Let us take the classical case of CML. Whether we know any other translocation or not, we have to know about CML. That is translocation 922, also called as Philadelphia chromosome. Translocation 922 or Philadelphia chromosome. Which is the protein formed? It is associated with BCR ABL. See, what happens is normally in all of us, we have BCR on chromosome 22, ABL on 9. All of us have it. Chromosome 9 is separate, chromosome 22 is separate. We have BCR on 22, ABL on 9. They are sitting separately. When it breaks and they come together, that is, a new couple is formed, a new fusion transcript is formed, then it leads to cancer. So what is the protein formed? BCR ABL. What is the therapy of the same? We use TKIs, tyrosine kinase inhibitors. Most commonly used is the first line TKI, that is imatinib. Imatinib, trade name Gleevec. Imatinib or Gleevec. ठीक है, fair enough, मान लिया. So what do we do in FISH? I went to the chemist or I went to the company and said, give me the proteins for BCR ABL, give me red color for BCR, green for ABL. Fair enough. So normally I should see 2 red, 2 green. This is what should be visible to me normally, because BCR is on 22, ABL is on 9. I should see 2 red, 2 green. If translocation has occurred, that means if I'm able to see a yellow color, if a yellow color is coming, that means translocation is positive. This is FISH. Fluorescent in situ hybridization FISH. So it is used for detection of translocation 15, 17, 9, 22, 14, 18, 8, 14, whatever. If HER2 new is in excess, I'll be very glad. Surgery is done. Ekbar, please tell me this. You're done with surgery, right? Surgery recently happened in face-to-face classes, those of you who are enrolled with us. So HER2 new excess is associated with which cancer? Cancer of which organ of the body? I mean, no double meanings, but that is one of their favorite organs, I guess. Breast cancer. It is associated with breast cancer. For detection of HER2 new positivity or HER2 new excess, again, instead of normal HER2 new expression, you will see excess in number. If there is loss of chromosome 7, in that case, normally, if I put any marker on chromosome 7, I should see 2 of that markers. If there is a loss of chromosome 7, if there is deletion, I'll just be able to see 1 expression. I can detect all that by FISH, but I cannot detect point mutations by FISH. So all can be detected by FISH except point mutations. Next question. This gets us to abnormal folding of protein is seen in which of these conditions? When we talk with respect to extracellular abnormal folding of protein, then we can even talk with respect to amyloidosis. Amyloidosis, a much more important topic than this one which was asked. Acha, I always say this. Targeting INI is extremely good for life, but being practical is getting a very good rank in your NEET MDS exam and getting out of this stupid rat race. So with respect to this question, yes, abnormal folding of proteins, the examiner was talking with respect to prion diseases. He was talking with respect to prion diseases, that most common prion disease, most common being Creutzfeldt-Jakob disease. Extracellular abnormally folded protein is also amyloidosis. So before we go to prion diseases, Divine, you are right. Point mutation was the answer to that of FISH. Quickly tell me classification of amyloidosis. Primary amyloidosis, which protein is getting deposited? The one with multiple myeloma. Which is the protein getting deposited? Keep on commenting in the chat box. Whereas secondary or reactive amyloidosis, the most common cause of which is rheumatoid arthritis. Most common cause of which is rheumatoid arthritis. Next, beta 2, next, hemodialysis associated amyloidosis. Hemodialysis associated amyloidosis. Keep on telling me the proteins getting deposited. Alzheimer's disease. Most common cause of dementia in elderly? Alzheimer's disease. And lastly, which thyroid cancer shows amyloid deposition? Medullary carcinoma thyroid. Tell me the proteins getting deposited. Primary amyloidosis, AL. Amyloid light chain. Primary amyloidosis, AL. Versus secondary amyloidosis, AA. Serum amyloid A protein, AA. Hemodialysis associated. How many kidneys do we have if we have not purchased the latest iPhone 17 or something? How many kidneys do we have? 2. Beta 2 microglobulin. वैसे हम में से किसी ने वो iPhone लिया है क्या? I mean, I don't know. Personally, I use Android. I use all Android products, including my laptop, this, that. So I can't relate to the craze of Apple. But its camera, I guess, is off the charts. So how many kidneys do we have? 2. Beta 2 microglobulin. Hemodialysis associated beta 2 microglobulin. We have one brain. Alzheimer's disease, the protein is A beta. Which thyroid cancer is associated with amyloid deposit? Medullary carcinoma thyroid. So which protein is getting deposited? ACAL. Amyloid calcitonin. That is why the tumor marker of medullary carcinoma thyroid is calcitonin. It is calcitonin. It's okay. I don't think any of us is missing out on anything in life if we have not purchased that iPhone. And it is never about गरीब और अमीरी. I mean, come on. उसको EMI पे भी ले सकते हैं, but point नहीं है. I guess some of the girls might be into iPhones. आज किसको gossip बहुत कम लोग कर रहे हैं. I guess the gossiping people are having the live class. But coming back, I know, beautifully said, Abdullah. So coming back, abnormal folding of proteins, in this case, the examiner was talking with respect to amyloidosis. He was talking with respect to prion diseases. That is why the answer was Creutzfeldt-Jakob disease. So starting with prion diseases, prions, they are abnormal forms of cellular protein. What do we mean by this? We'll just see within a second. They are associated with 4 main disorders. The most common being Creutzfeldt-Jakob disorder. Most common being Creutzfeldt-Jakob disease. Others are Gerstmann-Straussler-Scheinker syndrome, fatal familial insomnia. Fatal, patient is not able to sleep. Familial insomnia, fatal familial insomnia, and Kuros disease. These are the 4 prion disorders. देखो, okay. Okay. So, Creutzfeldt-Jakob, Kuros disease, fatal familial insomnia. ये तो हमेशा याद रहता है. What we need to remember are the Gerstmann-Straussler-Scheinker syndrome. The option will be there in front of you. Clinically, prion disease, but it is associated with rapid progressive dementia. The patient will be undergoing dementia, which is rapidly progressive in nature, with the microscopic hallmark being spongiform change. So if you are given a clinical history, you classically in Path and Micro, you have classical 2-3 line history-based questions. If there is a history of rapidly progressive dementia with spongiform change, the examiner is talking about prion diseases. Lastly, it is associated with abnormal forms of cellular protein. That means the protein, the PRP protein, undergoes a conformational change from normal alpha to abnormal beta pleated sheets. What is the conformational change? From normal alpha to abnormal beta pleated sheet structure, to abnormal beta pleated sheets. This is prion disorders. This is prion disease. Next point. So for making a diagnosis, protein की abnormality है ना. That is why we do Western blotting. Western blotting is for proteins. Southern blotting, dosana, DNA. Northern blotting, RNA. Western blotting, proteins. Next question. Now tell me the answer to this. I'll wait for your answer on this one. I'll give you a hint though. Many people in the population acquire hepatitis B, but they remain asymptomatic. What is the frequency of transmission of hepatitis B to chronic liver disease? Less than 5%. What is the frequency? Frequency of chronic liver disease. Frequency of chronic liver disease with hepatitis B virus. Frequency of development of chronic liver disease. Hepatitis A and E is never. We never get chronic liver disease by having dhaba food. A and E are transmitted by fecal route. Hepatitis B, but the frequency is less than 5% versus hepatitis C where the frequency is 80%. Hepatitis D, depending on whether it is co-infection or superinfection, frequency is 10% versus 70%. We'll see that later. Now the point here is, hepatitis B, the frequency of chronic liver disease is less than 5% versus 80% of hepatitis C. But most common cause of chronic viral hepatitis, being hepatitis B virus. This is what the first line of the question tells you. Hepatitis B is so common that even though the frequency of development of chronic liver disease is less than 5%, but it is the most common cause of chronic viral hepatitis. ठीक है, मान लिया. Agreed. So many people develop acquired hepatitis B, but they remain asymptomatic. Less than 5% progress to chronic liver disease. But with aging, they develop hepatocellular carcinoma. Hepatitis B, HBV, hepatitis B as well as HPV, human papilloma virus. But both of them are DNA viruses. And the main risk factor for development of cancer with both hepatitis B is HCC, HPV, human papilloma virus is cervical cancer. The main risk is when the viral DNA incorporates with cell DNA. What does this mean? Dekho, like when we talk with respect to cervical cancer, HPV, this is the host cell with the host genome. That is, this is the host DNA. HPV as well as hepatitis B virus, they are DNA viruses. So they are present as extra chromosomal material. They are present as extra chromosomal material called as episome. The main risk for carcinogenesis, main risk for cancer is integration of episome. When this episome integrates with host genome, integration of episome with host genome. This is the main statement that has to be marked. This is what option C told us. It is not integration of HPX protein causing oncogenesis. No, it is the viral DNA which incorporates with the cell DNA. That was the best answer. Next point. Now have a look at this one now. Now, simple, straightforward question I am saying so because the image itself is self-explanatory. Young child had multiple cervical lymphadenopathy since 3 years. Biopsy of the lymph node is given below. Now, the options itself says Hodgkin's, non-Hodgkin's. So, the minute I see this cell, I am very comfortable with the fact that this is a classical RS cell. It is a binucleate cell with prominent eosinophilic nucleoli. It is a large binucleate cell with eosinophilic nucleoli, giving it the classical owl-eye appearance. That is classical Hodgkin's lymphoma. Yes. When sir, so we'll have a look at the vaccines, but we'll come to that. Recombinant vaccine is used, no? We'll come to that. So it is a case of Hodgkin's lymphoma along with the presence of RS cells, Reed-Sternberg cells. There is a question on vaccines. Vaccines are again important. We'll see that. Hodgkin's lymphoma, RSL, Reed-Sternberg cell. And Hodgkin's lymphoma is associated with which virus? Epstein-Barr virus. Asha, before we go further, RS cells, the classic RS cells, they are which markers positive? They are 15-30. They are CD15 positive, 30 positive. Next point. This gets us to the classification of Hodgkin's also. If you know this classification, you will know everything about Hodgkin's. Hodgkin's, which it is divided into two types. Classical versus lymphocyte predominant. Acha, which infection is associated with owl-eye appearance? Other than Hodgkin's lymphoma, which infection shows owl-eye appearance? You know this? CMV, Rena agreed. Cytomegalovirus, CMV. Classical Hodgkin's, which it is of four types. That is mixed-LRT, nodular sclerosis, mixed-LRT, nodular sclerosis, lymphocyte rich and lymphocyte depleted. Lymphocyte rich and lymphocyte depleted. Manali agreed, CMV. Whereas the other side is lymphocyte predominant. Which is the most common Hodgkin's in India? Mixed LRT. Whereas secular country, mixture of everybody, most common in India, mixed LRT. Whereas most common in West, nodular sclerosis. Next point. Best prognostic Hodgkin's, lymphocyte predominant. More the number of lymphocytes, better is the prognosis. Versus lesser the number, worse prognosis. So worst prognostic Hodgkin's, lymphocyte depleted. Now Hodgkin's lymphoma, it is associated with two viruses, HIV and EBV. Most common Hodgkin's with HIV, mixed LRT. Most common Hodgkin's with EBV, mixed LRT. So if you don't know the answer to something in Hodgkin's, the answer is mixed LRT. Now listen to this once for all. There are four classical Hodgkin's. All the classical Hodgkin's are EBV positive. Which is the EBV negative Hodgkin's? The other side. That is lymphocyte predominant Hodgkin's. That is why we divided Hodgkin's into two types, classical versus lymphocyte predominant. It is EBV negative. And the RS cell seen in lymphocyte predominant Hodgkin's, but it has a special name to it. That is a popcorn cell. It looks like a popcorn. RS cells are 15-30 positive, except popcorn cell, which is CD15 negative, 30 negative. So what is it positive for? It is CD20 positive. Easy to remember when we are haggling with the shopkeeper. He says 30, you say 15. We settle at 20. Though if we are guys, we'll settle at 25 or 28 only. But girls, we settle at rupees 16 or 20. So it is CD20 positive. This is Hodgkin's. This was the master table of Hodgkin's. This was what this question was about. Next question. Match the following. Match the following with respect to the disease. QH mount was asked this time in NEET MDS paper also. So potassium hydroxide or QH mount. Again, very, very important. So if we just know that QH mount is with fungal diseases. It is with fungal diseases. Lip biopsy, irrespective of how painful it is, has to be performed for Sjogren's syndrome. That is dry eyes, dry mouth. Sjogren's syndrome. Tell me the antibody associated with Sjogren's. Tell me two questions with Sjogren's. Main inflammatory cell and the antibody associated with Sjogren's. Tell me this, and then tell me the antibody with systemic sclerosis. Antibodies are important, bache. Sjogren's is dry eyes, dry mouth. That is, which are the organs affected? What keeps our eyes and mouth wet? No double meanings. Lacrimal and the salivary glands. So the main inflammatory cell in Sjogren's is the lymphocyte. Main inflammatory cell being lymphocyte. That is, it is associated with lymphocytic infiltrate in lacrimal and the salivary gland. And the antibody seen is anti-Rho/LA antibody. It is associated with anti-Rho/LA, also called as anti-SSA/SSP antibodies. This is Sjogren's lymphocyte. Agreed. Next, PTHSA, brown tumors. The answer was easy. 1A, 2B, 3C, 4D. Agreed. The answer in this case was easy. So that is why I want to know about antibodies seen in autoimmune disorders. INI paper, bache, they are obsessed with antibodies. So systemic sclerosis, you very well know that it is of two types: localized versus diffuse type of systemic sclerosis. Systemic sclerosis, it is of two types: localized versus diffuse type. Localized type, it is involving the face and the peripheries, versus diffuse, face, peripheries, and trunk is also involved. So diffuse, it involves everything, doesn't matter. Antibodies. Girls, when you are scolding us, what do you say? You are so localized to yourself. You are so centric to yourself. तुम्हें बस अपनी पड़ी है, दूसरे की तो चिंता ही नहीं है ना. So it shows the presence of anti-centromeric antibody. Localized type. Anti-centromeric antibody. Versus diffuse, which shows the presence of anti-RNA polymerase 3 and anti-topoisomerase. Anti-RNA polymerase 3 and anti-topoisomerase, also called as anti-SCL70 antibody. Also called as anti-SCL70 antibody. These are the antibodies associated with systemic sclerosis: anti-RNA polymerase 3 and anti-topoisomerase. CREST syndrome. CREST syndrome is associated with localized or diffuse type. It is more common in localized, rare in diffuse. I know CREST syndrome, calcinosis cutis, this, that, Raynaud's phenomena, esophageal dysmotility. We think that so many things are happening, it would be with diffuse. But no, CREST syndrome is more common with localized type. So this question is also asked as antibody associated with CREST syndrome, anti-centromeric antibody. Again, important though. So Sjogren's syndrome, anti-Rho/LA antibody, versus systemic sclerosis, localized versus diffuse, you know the antibody is associated. SLE, I am sure, butterfly-like rash, photosensitivity, malar rash. Most common antibody is ANA. SLE, systemic lupus erythematosus, most common antibody associated is ANA, anti-nuclear antibody. Most specific, S for specific, S for Smith, anti-Smith, followed by anti-double stranded DNA antibody. Anti-Smith, followed by anti-dsDNA, double stranded DNA antibody. These are the antibodies associated with lupus. Perfect, agreed. I'm not even getting into drug-induced lupus, भी बता दो. Homogeneous pattern, वाह, Manali, agreed, totally agreed. So there are actually 4 patterns of immunofluorescence with ANA, but dental, you will not be asked this much depth. So we'll see which is the pattern later. Next, drug-induced lupus, मुझे antibody बता दो. I'll be extremely glad if you are able to tell me the antibody with drug-induced lupus, and then it will get us to this question. Antihistone antibody. Drug-induced lupus, antihistone antibody. Next question. Metastatic calcification is not seen in. Metastatic calcification is not seen. It is not seen in 1, 2, 3, 4. Answer, bache. If you say, I'll slightly enlarge it also so that you're able to see it clearly. Answer. You know this. Calcifications are of 2 types. Dystrophic, metastatic. Dystrophic, let me quickly make the master table of this. Dystrophic, but it is seen in dead or damaged tissue, versus metastatic calcification, which is seen in normal tissues. You know this. Most common site being lungs. Other than lungs, it is also seen in kidney and stomach, versus dystrophic calcification, which is seen in dead or damaged tissue. So serum calcium levels in dystrophic calcification is normal. Calcium in the blood was normal, so it went and got deposited in damaged tissue. Versus metastatic calcification, where serum calcium is high. That is why it goes and gets deposited in normal tissue. Examples of dystrophic calcification. Asha, tell me the examples. Which is the one which is associated with tumors? Calcification associated with tumors? it is called as psammoma bodies. Calcification associated with tumors, that is psammoma bodies. Next, it is seen in atherosclerosis. Most common cause of narrowing of blood vessel, atherosclerosis. Tubercular lymph node because it is damaged tissue. Versus chondrocalcinosis, others, milk alkali, all those are metastatic calcification. One of the main examples of metastatic calcification is multiple myeloma. Please do not go wrong in this at all. Elderly with low back pain. Which blood cancer? Multiple myeloma. Multiple myeloma. हाँ ना, spelling mistake चलती है. Manali, absolutely no doubt about this. You need not correct your answer for spelling mistakes. I'm not gonna pull your leg. If it was a app-based class, I would have certainly pulled your leg about your name, but not on YouTube. So you are saved today. It is multiple myeloma. It is a malignancy of plasma cells with graft features. Remember, calcium is increased. Renal insufficiency, anemia, bone lytic lesions. So calcium was increased, na? That is why it is metastatic calcification. Multiple myeloma was important. Next point. This gets us to the next one. ये तो बहुत ही obvious सा question है. All of these are tumor suppressor genes except. Answer. Which is the main? Tell me the chromosomes associated with these also. All four. But I know the question that was asked was simple, straightforward. But this question has numerous prospective questions which can be asked in your paper. So tell me the chromosomes. Which is the molecular policeman? Molecular policeman or guardian of the genome? Which is the molecular policeman or guardian of the genome? Answer. Versus governor of the genome. Keep on telling me the answers. Don't ask me the difference between guardian and governor. This is what is classically said. Whereas new molecular policeman of the genome. New molecular policeman of the genome. Firstly, let us start with molecular policeman or guardian of the genome, that is P53. Present on chromosome, see P53 है ना, so this is the one which is on short arm. P, that is chromosome 17p13. Chromosome 17p13, P53. Versus governor of the genome, that is RB gene chromosome other than P53, and which is the gene mutation associated with renal cell carcinoma? VHL gene mutation, one Apple Lindau gene mutation. How many alphabets are there in VHL? 3. Present on chromosome 3p. These are the only 2 gene mutations which are present on short arm. P for petite is the short arm. Other than this, everything is on long arm. So RB gene, chromosome 1314, that is 13q14. Versus new molecular policeman is the P10 gene, that is chromosome 10q. All these are the tumor suppressor genes which act mainly at G1S checkpoint. There are 2 checkpoints, G1S, G2M. Which is the main cell cycle checkpoint? G1S, main being G1S. Next point. So all are tumor suppressor genes except MYC, which you were telling me very rightly. MYC is a proto-oncogene. MYC is of 3 types. मुझे फटाफट से बता दो. CMYC, NMYC, LMYC. Tell me the malignancies associated. CMYC, Burkitt's lymphoma, translocation 814. The minute you have a history of a young male with rapidly enlarging jaw mass, young male with rapidly enlarging jaw mass, not associated with food intake, it is a case of Burkitt's. CMYC, Burkitt's, translocation 814. The one with Stariska appearance on lymph node biopsy. CMYC. All these are the PYQs. Versus NMYC. N से कौन सा malignancy है? Neuroblastoma. Versus L. Which organ in English starts from L? Of the leg read, lungs. No double meanings. Lungs. So, small cell carcinoma lung. Which lung cancer? Small cell carcinoma lung. This is with respect to MIC. This is with respect to MIC. You know this. You know this. So MIC was a proton cogene. It was a proton cogene, whereas all others were tumor suppressor gene, which act mainly at G1S checkpoint. So main cell cycle checkpoint being G1S, end of G1. नेक्स्ट पॉइंट एग्रीड. अच्छा, मुझे एक और क्वेश्चन बता दो, ये भी इसमें से पूछा जा सकता है. मोस्ट कॉमन malignancy with RB gene mutation is RB, retinoblastoma, followed by which is the second most common malignancy with RB gene mutation? See, nobody is going to ask you most common with RB gene mutation is RB. That is obvious. Which is the second most common malignancy with RB gene mutation? Osteosarcoma. So most common is retinoblastoma followed by a osteosarcoma. Agreed. Next point. What is a totipotent cell? Totipotent, बच्चे, it is a cell which is able to differentiate into all. देखो, there are many types of cells. Let us start with totipotent. Totipotent cell, it is the ability of a single cell to divide and produce all of the differentiated cells in an organism. It is able to differentiate into all the cells, like spores or zygote. That is where it's a totipotent cell. It is able to differentiate, into all the cells of an organism. Versus pluripotent. So toti, agreed dear Reena, totally agreed. It is able to differentiate into all the cells in an organism. That is totipotent. वो तो बिल्कुल टोटा है ना, जैसे मतलब I am a Punjabi, so that is what we guys say. बिल्कुल तोता या तोता नहीं बोला जाता है, ऐसे टोटा है. That is, it is able to differentiate into all. Versus pluripotent. Pluri काफी में कर रहा है, सब में नहीं. Able to differentiate into any of the three germ layers, ectoderm, mesoderm, endoderm, but not into extraembryonic tissue like placenta. So these are the embryonic stem cells. It is able to differentiate into any of the three germ layers. Pluripotent. Multipotent, काफी में कर रहा है, differentiate into discrete cell types. जैसे blast, in bone marrow blast, they can differentiate into neutrophil, lymphocyte, monocyte, eosinophil, basophil. Multipotent. Versus oligopotent. Oligo मतलब कुछ cells में differentiate कर पा रहा है. Oligopotent, that is ability to differentiate into few cell types. Blast are of two types, myeloid blast, lymphoid blast. Lymphoid blast can just differentiate into B or T cells. So oligopotent, lymphoid stem cell or myeloid stem cell, oligopotent. And lastly is unipotent, where it is the ability to differentiate only into one cell, unipotent. Hepatoblast will only form hepatocyte. So totipotent into all, pluripotent, all three germ layers. Multipotent बहुत सारे, like blast. Oligopotent, lymphoid blast or myeloid blast. मतलब they are able to differentiate into few cell types. Unipotent तो एक ही में है. This was with respect to the potency of cells. First class बच्चे. So this takes care of the PYQs and with respect to pathology. I just wanted to show you quickly few images, 3 high-yield topics which are asked. Genetics में से the images, the questions which many of us go wrong in, and 2 pedigree charts, and that will wrap up path, and then we'll quickly go to microsection. The minute you have such an image, that is, it is the most common genetic cause of mental retardation, radiologically increased nuchal fold thickness, epicanthic folds with a flat facial profile, face चिपटा हुआ है with a single transverse simian crease. This is given in the question. मुझे फटाफट से बताते जाओ. Diagnosis. I'm waiting for your answer on this. Diagnosis. Next, which is the most common CVS abnormality associated with this? It is associated with intestinal stenosis at duodenum. It is a case of Down syndrome. So, which is the most common CVS abnormality associated with Downs? Patient has increased gap between first and the second toe. That is called as saddle toe deformity. Saddle is the patient is sitting on a horse. Saddle toe deformity. Hypotonia. The the tone of the muscles is reduced. Umbilical hernia. Recent PYQ, umbilical hernia is not associated with Turner syndrome. It is associated with Downs and increased risk of leukemias. Answer. Which is the most common serious abnormality with Downs? Endocardial cushion defect. Most common serious abnormality बच्चे पूछा जाता है is endocardial cushion defects. Endocardial cushion defects followed by VSD, ventricular septal defect, followed by ASD. Most common is endocardial cushion defect. Which is the most common leukemia seen in Downs? Tell me the answer to this also. I'm waiting for your answer. Most common leukemia. Very commonly asked. Most common leukemia associated with Down's peak. When we talk of Down syndrome, what comes to your mind? Downs is seen in children or adults? It is seen in children. Down syndrome, it is seen in children. Most common leukemia seen in Downs being ALL, acute lymphoblastic leukemia, ALL. Because which is the most common leukemia in children? ALL. Agreed, मान लिया. Whereas most common AML in Downs. Please have a good look at this. Most common AML in Downs being AML M7. You know that we divide AML into M0 to M7. Overall, M7 is the least common AML, but it is the most common AML in Downs. Agreed. Next point. Tell me the diagnosis. Next, tell me IQ in her, low, normal, high. Tell me FSH and LH, low, normal, high. Tell me these three answers with this. Now, the minute I see this, suppose she is a 16-year girl, she has a short stature, low web neck, widely spaced nipples, streak ovaries. That is, it is associated with primary amenorrhea. Diagnosis, Turner syndrome. That is 45XO. You very well know girl is 46XX. One X chromosome is less. So secondary female sexual characteristics are reduced. You know that. So IQ. Manali, you were the first one, right? Hamna Rina Abdullah, totally agreed here. So IQ, low, normal, high. I know I'll not say that stupid statement, at least on YouTube, that more the number of X chromosomes, lower is the IQ. After normal. So as Reena has very rightly told us, this is XO. One X is less na, so IQ is normal. IQ high nahi bolna. IQ normal. Then she is a case of primary amenorrhea. The girl has never bled. So her hypothalamic pituitary axis is trying to stimulate the ovaries. So FSH and LH is high. This is Turner's. Because the body wants the girl to bleed. So FSH and LH is high. That is Turner's. And lastly, when you are given this image, that is a male. How do we know he is a male? Because he has testis with penis. There is female type pubic hair distribution with atrophic testis. Small testicular size. That is atrophic testis. So recent PYQ was also there. That is a couple married for the past 6 years is not able to conceive. On examination, the girl is normal, but the male has unicoid body habitus. Unicoid body habitus means the patient has female-like body habitus. Narrow shoulders with broad hips. See, males have broad shoulders. Females have narrow shoulders with broad hips. That is Klinefelter's. Most common Klinefelter's being 47XXY. So fewer chest hair, frontal baldness is absent, gynecomastia with long arms and legs. The patient has low IQ. More the number of X chromosomes, lower is the IQ. Low IQ. Next, FSH and LH. Low, normal, high. But the number of X chromosomes are more now. So FSH and LH is increased. That is why estrogen to testosterone ratio is also increased. So this was a case of Klinefelter syndrome. Perfect. And lastly, before we wrap up the high yield points with respect to this, tell me a pedigree chart, something like this. Suppose you are given a pedigree chart. You are given a pedigree chart like this. Your options are autosomal recessive, autosomal dominant, X-linked recessive, mitochondrial, Y-linked. Everybody, bache, everybody. I want all of you to tell me this pedigree chart analysis. Everybody. And then we'll go to our next extremely important topic, that is hepatitis B virus, with the recent NEET MDS PYQ as well as INI PYQ. We'll have a look at that. So, but before we go further, I'm waiting for your answer. I'm waiting for your answer on this. Fatafat se autosomal recessive, dominant, X-linked recessive, mitochondrial, Y-linked. Everybody. Dekho. Look at this family first. Look at this family. This is not a consanguineous marriage. Hamna bache, I'll start with you. This is not a consanguineous marriage. Consanguineous marriage is marriage between cousins, which is shown by a double line. So this guy is normal. If you assumed it to be autosomal recessive, you assume that the girl is carrier, but this guy is normal. In autosomal recessive, if one parent is carrier, the other is normal. Risk of child to be diseased is 0%. I'll repeat this. It cannot be autosomal recessive because of this. Because in autosomal recessive, if one parent is normal, the other is carrier, risk of child to be diseased 0%. It cannot be autosomal dominant because one of the parent, if it was autosomal dominant and the child is diseased, one of the parents had to be diseased for the child to be diseased, so it's not autosomal dominant. It is not mitochondrial. If it was mitochondrial, if the mother is diseased, all her children are diseased. It is not mitochondrial. It is not Y-linked. In Y-linked, all males are diseased. Suppose this Y chromosome is abnormal, it will go to this male also. If this Y chromosome is abnormal, this male will also be diseased. So Y-linked, all males are diseased. It is not Y-linked. So what is left? As you told me very rightly, Reena and Manali, bang on right, it is X-linked recessive. Only males are diseased. Only males are diseased. And what is the relation between this guy and this guy? Mother's real brother. Who is mother's real brother? Mama. So Mama Bhanja diseased. Mama Bhanja deceased. This is classical X-linked recessive. This is classical X-linked recessive. Pedigree chart. This is the most tricky of all pedigree chart. These five you need to know: autosomal recessive, dominant, X-linked recessive, mitochondrial, Y-linked. So tell me the answer to this. Tell me the answer to this. X-linked recessive, I am again saying this. You were given this pedigree chart in this NEET PG PYQ MBBS segment, and you were asked the disease associated with this is. 4 options were given. The answer to be marked was Viscott-Eltis syndrome. So examiner can give you pedigree chart and ask the disease associated. So you need to know the diseases associated with particular inheritances. Next point. Now tell me this. Inheritance. This is carrier state. When 2 carriers mate with each other, the children are diseased. This is autosomal recessive. This is autosomal recessive. I guess plain, simple, straightforward. बिल्कुल चिंता की कोई बात ही नहीं है. This is autosomal recessive. Versus. Now have a look. At this. I want you to tell me this. You know this. The minute I see this, first have a look at males and females. 3 males, 2 females are affected. That means males and females are equally affected. So it is not sex-linked inheritance. See, when there are 3 males, 2 females, we don't say it is male predominant or female predominant or something like that. No, males and females are equally affected. So it is not sex-linked inheritance. It is not sex-linked, firstly. Secondly, it does not skip generations. if the child is diseased, one of the parent has to be diseased for the child to be diseased. So this is autosomal dominant. First class. So this takes care of our most important high yield topics with respect to path and its integration with medicine. And let us quickly have a look at few main topics of microbiology also. One of the most important topics being hepatitis B virus. Hepatitis B, this is a topic that was asked in both recent INI as well as the INI MDS segment as well as the NEET MDS segment. So you need to know this. Hepatitis B. There are three antigens. It has first tell me the answer to this. I'll wait for your answer also, and by the time I'll give you the explanation also. Patient with liver cirrhosis is evaluated for hepatitis B. HBs antigen positive, and so anti-HBs antibody negative. HBe antigen positive. IgM antibody against HBC antigen negative. That is IgM anti-HBC antibody negative. Diagnosis. First, you tell me the answer to this before I give the explanation. See, that is how we learn. There are three antigens in hepatitis B virus. That is HBs antigen. HBs is the hepatitis B surface antigen or the Australia antigen. HBe antigen, that is envelope antigen. HBe, that is envelope antigen. And no, and HBC antigen, hepatitis B core antigen. These are the three antigens. These are the three antigens. It will have three associated antibodies: anti-HBs, anti-HBe, anti-HBC antibody. एक बार बच्चे, everybody please understand this question very well in one go only. Hepatitis B, the serology is very, very important. I cannot emphasize this more. Next point. Hepatitis B core antigen. Hepatitis B core antigen. हमने देखो अपने दो आंसर गलत हो गए ना. HBC antigen is not secreted in blood. It is not secreted in blood. So answer to no question will be HBC antigen till the question is which of the following is not secreted in blood. Reena, no. So let us have a look at the serology of hepatitis B virus. Let us understand this question. Let's have a look at the serology. सबसे पहले, which is the first antigen to appear? Hepatitis B surface antigen. The first antigen to appear is HBs antigen. So till the time infection is present, HBs antigen will be positive. So which is the marker of chronicity? Which is the marker of chronic hepatitis B virus? HBs antigen. If HBs antigen is positive, it means disease is present. After the patient becomes all right, anti-HBs antibody is positive. The time period between appearance of HBs antigen and disappearance of HBs antigen and appearance of anti-HBs antibody is called as window period. So in this question, the answer can never be window period if HBs antigen is positive. For it to be window period, both HBs antigen and anti-HBs antibody has to be negative. When symptoms of the patient are at their peak, HBe antigen is positive. When symptoms are at their peak, HBe antigen is positive. So I can safely say, marker of viral proliferation. Marker of viral proliferation is HBe antigen. Why? Because virus is proliferating, that is why symptoms are at their peak. Hepatitis B virus is a DNA virus. Other markers of viral proliferation are DNA polymerase and HPV DNA copy number. Other markers are DNA polymerase and HPV DNA copy number. So if you are asked a question that what is the maximum risk of transmission of hepatitis B virus from mother to child? HBe antigen, because if the virus is proliferating a lot, that means it has the maximum chances of transmission from mother to child. Next point. When was HBC antigen coming in bloodstream? HBC antigen is not secreted in blood. So antibody against it IgM anti-HBC antibody. IgM anti-HBC antibody is positive since beginning. So which is the best marker of window period? Which is the only thing which is present in window period? IgM anti-HBC antibody. Which is the best marker of acute infection? Acute infection is denoted by IgM or IgG antibody. IgM antibody. Acute infection is by IgM anti-HBC antibody. If IgM antibody is present, it is acute infection less than 6 months. Best marker of window period, IgM anti-HBC antibody. Which is the first antibody to appear? IgM anti-HBC antibody. What is present post-immunization? What is present? Which is the first antigen to appear? HBs antigen. So when we are immunizing the cute little kid, we want to give a mimicker of HBs antigen. So antibody against it is present. That is anti-HBs antibody is present. Only anti-HBs antibody, nothing else. We are only giving a mimicker of HBs antigen, nothing else. You know all this just by this graph. Please have a good look at this graph. So let us now come back to the question. Now, HBs antigen is positive, means it can either be acute infection or chronic infection. IgM antibody is negative. That means it cannot be acute infection. It is chronic. It is chronic. If it is chronic, it can either be carrier stage or it can be chronic active. Chronic active means it is actively proliferating. Carrier means HBe antigen will be negative. HBs antigen told me it is chronic infection. It can be chronic active or carrier. That is option A or C. Please understand this very well. HBe antigen positive told me that it was actively replicating. It is a marker of viral proliferation, means it is a chronic active hepatitis, making the answer as A. It is not B. If it was immunized against hepatitis B, then only anti-HBs antibody will be positive. If it was carrier, then it was okay. But in this case, HBe antigen had to be negative, which is positive. Window period. What was the only thing which had to be positive in window period? IgM anti-HBC antibody, making the answer as A. Everybody, but please give me a thumbs up or like the video, put a heart if all of you are comfortable with all the points that we covered here, as well as the understanding of this question. Hepatitis B virus, a very, very important question. I cannot emphasize this more. Everybody, any queries, please ask me right now. This was important. Next question. I wanted to show you 3-4 microscopies at this point. This was, I think, last year's INI PYQ. What was asked was, this was during the COVID era, just after the COVID got over. That is, patient presented to OPD with respiratory distress, showing the presence of both septate, acute angle branching, as well as aseptate hyphae. It was an infection. I know, Zareen, I know it was slightly tough to understand. I'll go back. Let me just take care of this. Then I'll go back. Showing the presence of both septate, acute angle branching, and aseptate hyphae. It was an infection by both aspergillus and mucor. Mucormycosis, which shows the presence of aseptate or minimally septate hyphae, which are present at right angles. Whereas septate hyphae with acute angle branching is aspergillus. It is septate hyphae with acute angle branching, aspergillus. Next, before I go to that, please have a look at this once again. Have a look at the graph once more. The first antigen to appear is HBs antigen. Let me highlight it side by side. The first antigen to appear, HBs antigen. After the antigen disappears, after a long time comes anti-HBs antibody. The time period between the two is called window period. So if the answer is to be window period, HBs antigen and anti-HBs antibody both have to be negative. When the symptoms of the patient are at their peak, HBe antigen is positive. This is HBe antigen is positive. So I can safely say marker of viral proliferation By mistake, HB antigen got disappeared. So I can safely say marker of viral proliferation is HB antigen. Hepatitis B virus was a DNA virus. Other markers of viral proliferation are DNA polymerase and HBV DNA copy number. DNA copy number means which are the exact number of copies of hepatitis B virus. Which is the first antibody to appear? IgM anti-HBC antibody. HBC antigen is not coming in bloodstream. So the first antibody to appear, IgM anti-HBC antibody. So it is the best marker of window period also. And this IgM, because it is IgM antibody, so it will disappear within 3 to 6 months. So it is the best marker of acute infection also. It is the best marker of acute infection also. And lastly, what is seen post-immunization? When we are vaccinating the cute little kid, we are giving a mimicker of HBs antigen. So antibody against it, that is anti-HBs antibody is positive. So till the time HBs antigen is positive means infection is there. Either it can be acute infection or it can be chronic. Let's make a flow chart. Let's make a flow chart and tell me this. If HBs antigen is positive means infection is present. It can either be acute infection. If it is acute infection, what will be seen along with it? IgM anti-HBC antibody. Because what was present in acute infection? IgM anti-HBC antibody. If it is chronic, if IgM antibody is negative means it is chronic. Chronic infection can be of two types. It can either be carrier state, that is the virus is not actively multiplying, or it can be chronic active hepatitis. If it is carrier state, means HBe antigen will be negative, versus if it is chronic active, which is the marker of viral proliferation, HB antigen. So in our question, we had HBs antigen positive, anti-HBs antibody negative obviously, IgM antibody negative, that means it is not acute, HBe antigen positive, making the answer as chronic active hepatitis. Now I hope everybody is okay with this. Everybody. Fair enough. So this gets us to our next set of questions. That is, have a look. Now have a look at the microscopies. I just want to show you 3-4 images. I know it is getting late and we have to take our dinner also. Mess के क्या timings है अपने last 5-7 minutes. Last 5-7 minutes. Just have a look at these microscopies and then we wrap it up. Done. So the minute I see this, देखो बच्चे, as compared to a neutrophil, all these are neutrophils. As compared to neutrophil, we see the presence of large organisms. That is, these are yeast, along with budding forms. That is, this is figure of 8 appearance. It looks like 8, figure of 8, seen in blastomycosis. Blasto को देख के ही 8 लग रहा है ना. Blastomycosis is figure of 8 appearance. Which is the stain used for fungi? Which silver stain? We use Grocots or Gomoris. Methenamine silver stain. Which is the stain used? Grocots or Gomoris, methenamine silver stain. Which shows the presence of a very thick capsule. It shows the presence of a thick capsule. That is, this is blastomycosis, figure of 8 appearance. Versus, now have a look at this. This is of course not cryptococcosis. 4 options were there, but they were written in white. So, no, Abdullah, no, right now, I know he said that because the post classes, that is what I usually have. But those Navratri are going on and I don't want to be killed myself. So, pure veg till Dasharas. I'm very superstitious, yeah. I'm very, very superstitious. I believe in karma. Now coming back to this, what we see here is it is showing the presence of a cell. It is showing the presence of a cell which has single intranuclear inclusion. This is the nucleus with an inclusion with presence of a single intranuclear and multiple intracytoplasmic inclusions. single intranuclear and multiple intracytoplasmic. Blue या pink? Blue. Basophilic inclusions. Basophilic inclusions, giving it the classical auli appearance seen in cytomegalovirus, making this as a case of CMV pneumonia. Making this as a case of CMV pneumonia. Perfect ना, कोई बात नहीं. Next point. So this is what CMV looks like. Versus, now have a look at this image. Third, the options are not being marked. The third option here is Candida albicans, or it can be blastomycosis. Awesome, Manali. Seriously, I have a huge sweet tooth, yaar. Seriously. And Manali, अब तुमने इतना अच्छे से बोला है तो मैं बोल ही देता हूँ. मतलब till you gave awesome answers. There's no doubt about it. Plus, I think you're not in our full batch, because I would have known your name and I would have teased you, because जब से तुम आंसर दे रही हो ना, मेरे मन में मनाली आ रहा है कि I have to go there, probably post Diwali. कहाँ से है वैसे? And I'm sure your friends would have teased you a lot on your name. देख के मतलब तुमसे बात करते हुए ही ना ट्रिप बनाने का मन करता है. बट you are from the hills. Please tell me that at least. Next, so coming back, others. What do we see here? You are able to see the presence of pseudohyphae. देखो बच्चे, ये ऐसे फंगाई आ रहे हैं ना. It is getting branched anywhere बीच में से भी. It is not getting branched in the end. Okay, fair enough. तो वहां पे तो लस्सी है ना. Fair enough. So this is pseudohyphae. Pseudohyphae में वो कहीं पर भी बीच में से ब्रांच हो रहा है. That is a case of Candida albicans. It shows the presence of pseudohyphae. Do not confuse pseudohyphae. Every time the examiner will not write pseudohyphae per se. This time, pseudohyphae was given as a written PYQ. They can even show you the presence of an image. So this is pseudohyphae. Versus now look at this. It is showing the presence of branching forms. That is, this is acute angle branching. This is acute angle branching seen in Aspergillus. This is acute angle branching Aspergillus. Septate hyphae, acute angle branching Aspergillus. I am saying this because very, very important. All these, that Aspergillus was also written PYQ. Candida pseudohyphae was a written PYQ. Examiner can give you the image. Cytomegalovirus, auli appearance was a written PYQ. And lastly, Cryptococcus is always a favorite question. Nigrosin staining, Indiaic preparation, meningitis, Cryptococcosis. This is what it looks like. So 4, 5, these are the prospective questions. They have not been asked in paper till now, but these are the prospective images that you need to know. Lastly, as well, Hana, Zareen, yes, after solve, yes, बच्चे, because देखो pseudohyphae का INI PYQ था, Cryptococcus India Inc. negative staining, nigrosin preparation कितनी बार पूछा गया है. Aspergillus का वो written PYQ था, mucormycosis with Aspergillus, the answer to be marked in which both acute angle branching with aseptate hyphae. So why can't the examiner give you these images? No? You need to know them. No doubt about it. So blastomycosis was that figure of 8 with thick capsules seen on GMS, Grocots and Gomodes, methanamine cell. This was the question that was asked. Pseudohyphae, vertical branching pseudohyphae, that is, the minute pseudohyphae is written Candida, they can give you that image of pseudohyphae, Candida. Lastly, एक bodies और कर लेते हैं. I wanted to do this question of bodies also with you guys, and then we wrap up our today's session. HP bodies, देखो सबको पता है, it is seen in molluscum contagiosum. The minute we talk of Henderson-Peterson bodies, the minute we talk of HP bodies, molluscum contagiosum, all of us know this. But this table itself was asked thrice last year INI. We can divide the viral inclusion bodies into two broad categories. they can either be intracytoplasmic or intranuclear. They can either be intracytoplasmic or intranuclear. Which are the intracytoplasmic bodies? HP bodies, totally agreed here. HP bodies, Henderson-Peterson bodies, molluscum contagiosum. What is the fancy name of body seen in rabies? It's always the black dog that bites, na? Nigri bodies. Nigri bodies, rabies. Nigri bodies, rabies. ये हमें पता ही है. Nigri bodies will be seen for making a diagnosis. Antemortem या postmortem? Okay. Okay, agreed. Done. Next point. So, Nigri bodies, black dog bites. So, it is a feature of, it is a postmortem finding because you will do a postmortem biopsy of the hippocampus. अब अगर live patient है, he is coming to your OPD with a history of dog bite, you will not do a brain biopsy. It will lead to more problems or more deficits. Smallpox coronary bodies. अगर हम ये नीचे के तीन नहीं भी याद रखेंगे, I'm okay with it. Main point here are the intranuclear bodies. They can either be acidophilic or basophilic. Cowdery type A. A are acidophilic, B are basophilic. Cowdery type A bodies are seen in varicella zoster, herpes simplex, and yellow fever. Cowdery type A, hay, HAY. HAY, Cowdery type A, that is seen in herpes simplex, Cowdery type A, yellow fever, and varicella zoster. Versus Cowdery type B bodies, which are seen in polio, adenovirus, and cytomegalovirus. CAP. Cowdery type B are seen in CAP. Cytomegalovirus, adenovirus, poliovirus. Point to be noted here is Cowdery type B body of poliovirus is acidophilic. ये बहुत important है. Cowdery type B body. BUP. Bang on right, Manali. Bang on right. Cowdery type B body of polio is acidophilic. तो पोलियो वाली एसिडोफिलिक है, बाकी बेसोफिलिक है. कैप था साइटोमेगलोवायरस, एडिनोवायरस एंड पोलियो. फर्स्ट क्लास. So I know we took this session slightly for a longer duration because I wanted to cover both path as well as micro. Micro ke we have few more questions also, but that's okay. That's absolutely okay. The main topics that I wanted to cover in this session, all the high yield topics, especially inclusion bodies, we are left with the vaccines. We will do that in one of our next sessions. Absolutely not to worry, but again, an important PYQ. It's late and I know you guys have to go for mess also. So needless to say, bache, bestest of luck for the papers. Keep on working hard, keep on slogging hard, and do good things in life. Karma is a bitch. So on this note, we wrap up our today's session. And I am actually glad that I was able to interact with you guys on one of the holiest months for us, that is Navratris are going on and all. So take care, believe in yourself. How many of you are going for Garba? Very curious, very curious, because I know some of especially those of you from Gujarat might want to go, but paper aa raha hai, padhna hai, कोई फर्क नहीं पड़ता. एक दो दिन हुआ, I am saying so, नहीं तो रात में चले जाओ. Come back slightly sooner. Whatever, need to sleep the next day. Our life is too short to have regrets. Plus, you will compensate on the time. Like if you feel energetic and positive, everything will be compensated. Ghumao. It's okay. So on this note, take care, guys. Take care.